you once again. So two things that I wanted to tell. Yeah, Dr. Santwana.
Ma'am, we'll just wait for Beauty to join in and then take the final group photograph, ma'am.
Sure. But I'm not sure if Beauty will be able to really join because she said her in-laws are not well and she's busy with them. So maybe we can have one picture now. And then if she joins, we will, And also, I would request all of you to share on your LinkedIn page as your, write-up like Gurleen has written, your own thoughts about the program. Thank you so much, Gurleen. I think you've given a wonderful, feedback, and I'm really humbled with your appreciation.
I wish I could write more, ma'am.
Thank you so much. Thank you. So Isha and Isha, and who else is there? If you could, have your
Renuka ji.
Yes, ma'am.
Renuka, yeah.
Good evening, ma'am.
Yeah. Just one second. We'll take a picture, Renuka. Isha, are you comfortable joining?
I'm not in a lie down position.
It's okay. Just show your face.
Even that's very important. I think, especially when the online programs are on. Oh, you don't really seem to. No. Isha,
You're not well at all. Bad.
No, my goodness.
Oh, we are so sorry.
Yeah. But I really appreciate your, commitment to the program, that in spite of being busy, unwell, having so many problems, you're still wanting to be here. I'm so thankful to all of you. So I'll quickly take a picture for all of us. Thank you. Smile. Thank you. So Isha, if you want, you can switch off your camera. Even Renuka, you can.
Thank you, ma'am.
Yeah. Be comfortable. It's all right. I know you're there with us. Okay. So the good news is the second program is announced. Hopefully it will start from 22nd of January. A couple of registrations already done. 2 doctors from Afghanistan, both gynecologists, are wanting to join the program. They seem to be more, in need of the session. So they were actually asking me, last time also, but somehow things didn't materialize. So hopefully this time they will be joining. 2 of them will be joining. So I'm seeking everybody's blessings and good wishes and inputs. What more do you want me to add to it so that it becomes, really, really meaningful, helpful, useful program, and it empowers people with the right skills.
And we are very privileged. Once before you become a very celebrated international trainer, so at least you'll say you are the first batch.
I'm going to be like this. I have always been like this. I'm going to be always like this. I'm not going to change.
Ma'am, all children are same for a mother, but the first batch is always special. The first two.
I know. So cute, so cute.
The first born is most cherished.
Yeah, I agree.
The mother is born, so the trainer, you have become a master trainer.
My pleasure. I am humbled with your words. I'm really humbled with your words.
Wishes for more programs.
Okay, so that was the news I wanted to share with all of you. Second is, as I said, we'll be having a next session about your assessment as well as your presentation. So please prepare seriously so that I'm happy to give you that certificate that yes, according to me, you are now good to go and you can, independently start working. And even later, if you need any help anywhere from me, any guidance, I'm there, you can anytime get in touch with me and I'll be there. So today's topic of discussion is a very sensitive topic and very important topic. I think we all agree to it. And that's when things go wrong. So we all know that usually the focus is on, avoiding to tell the patient or the family about anything has gone wrong. And usually if it hasn't harmed the patient, and if it is not in the knowledge of the patient, I think most of the times we see the effort is to avoid sharing but the problem is a patient or their family member would ultimately get to know, especially if it is something which cannot be hidden. And once they get to know, they are more upset about, not being told about what has gone wrong. And then they can go to the extent of, becoming violent, or, litigating the doctor or the hospital, even, creating all kind of ruckus. And we have seen this happening. So any one of you have experienced something like this, where the treating doctor did not disclose, and then later on the hospital or the doctor got into trouble? Any incident?
Generally, it's actually very rare, ma'am, because again, that is kept into a gray zone kind of a thing. So, is anyhow, at present scenario,
Yeah.
in our country, it has not become a trend till now.
Yeah.
Maybe there are very lesser instances, unless it is so criticality is involved.
Yeah.
So because wrong part surgery or this thing, where
Yeah.
the ultimate person will come to know.
Yeah.
So you are bound to tell them.
Yeah.
So you have to tell them.
Yeah.
Otherwise, if something happens in critical areas, ICUs and SCIUs, and then the teams are not so forthcoming in
Yeah.
coming out to the relatives or the parents.
Exactly. I completely agree with you. I think most of the times, if the patient is not aware, and if patient cannot get to know, or the family would not get to know, then it is not usually disclosed. But when you have amputated a wrong, Dr. Santana, 1 second. If you have amputated on the wrong side, or if you have operated on the wrong side, that is something you cannot hide, and you have to really come out and tell that. So that's where we have a great challenge, that we don't know how to handle that. And usually there is aggressive reaction or accusation from both the sides, and fight and violence that we experience. Yes, Dr. Santana, you wanted
Yeah,
to.
so this was just like while I was thinking that any case which I remember of, and yes, I remember of one of the litigation which is still going on in the court of law for one of the hospitals in Mumbai, wherein a 40-year-old man was admitted with some cervical pain, and he was asked by the doctor to get operated on the cervical vertebra, which was actually not necessary, but I don't know why. I have gone through the reports and all, and it was something which could, with physiotherapy, could have been treated. And this is what the doctors who have been looking after this case have also said. And they took him to the OT, and later on, someone came outside and got a consent form signed from the patient's wife, who did not know anything about it. And something went wrong during the operation, and he had hemorrhage, and he was brain dead. And it was like she was crying that he went in walking and he was all okay. He was not even on a wheelchair. Everything was fine. And then this hospital did not have any neurosurgery specialist. The surgeon had also come from somewhere outside, they had called, and it was a big mess. And they didn't have MRI, they didn't have any CT scan, nothing. So they did something went wrong during the operation, but the family was not informed about it, and it is still going on. The litigation is still on, and the doctors are not ready to accept that something went wrong. They said the patient bled and he had issues.
Yeah. So we know that, I mean, there are times when you are still able to prove yourself innocent, but then there are times when there is no scope for that benefit of doubt, and that's where you have to come out and disclose the facts. So probably this protocol is when although it's the individual's discretion whether you want to really come out clean and tell, but then as per the law, patient is supposed to be informed, or the family is supposed to be informed about what went wrong and how things are managed and what was done and what needs to be done. But we all know this is still a gray area, and not really being followed very meticulously, and a lot of cover up happen, and we have seen that happening across. So let me share the screen with you, and go to the presentation part, where I basically want to help you understand what is the situation right now and how we can make things work. Give me a second to. Okay, so this is one case I'm sure most of you must have read recently, not recently, but not very long ago. I changed the name, but this patient was admitted to one of the, very famous trauma center of Delhi hospital. He was admitted with head injury after a car accident, and he was mistaken for another patient who had a broken leg. And this patient underwent this surgery for repair of a fracture that he had not sustained. Second case, I'm sure even this you must have read in the news, that a physiotherapist was admitted in a hospital. She was a known case of high blood pressure. She had some ECG changes. They kept treating her for the ECG changes, but nobody realized that she was already she was a known case of hypertension, and unfortunately her hypertension was not controlled or not managed, and she went into cardiac arrest and she died. And two doctors were removed from their services on this case because they were found guilty of mismanagement of the case. This is another case where a lady was admitted for complaining of minor pain, and she underwent arteriovenous shunt for dialysis, being mistaken for another patient. So she was admitted for one reason, and she was operated for another reason. So if you look at all these three cases, I think the idea that we get it, that wrong side surgeries, wrong medication, wrong organ removal, wrong treatment, wrong patient, these are all very common things happening around us. Only thing is that these things don't get reported, so we don't get to see how much of it is really happening. So if I go by the rough estimates, I think the medical errors are something like 1:33,000. Like we have 33,000 errors happening in medical in the healthcare industry, and then we have one error in aviation or in nuclear industry. That's the comparison normally people give. And this I think I've discussed earlier also, just to reiterate that medical errors are the third commonest cause of deaths. So almost like 250,000 patients die annually because of the medical errors for no fault of theirs, just because of the mismanagement by the healthcare professionals. And this is a report of US. We haven't done any study in our country. I don't know if we did, where we would really stand. And a rough estimate by Professor Ashish Jha of Harvard University, he says 5.2 million medical errors happen annually in India. So almost like 14,000 errors every day. I believe these estimates are much wrong and much less than actual real situation. Again, the reason is that not all of us really, report these errors that happen. And most of the errors around the patient are on medication or about the patient care. A lot of them are about surgical or other procedures. Almost 18% of the errors are around. These 18% might seem very less, but it's a very, very high number. If we will calculate in terms of volume, it's a very high volume that I'm talking about. And most of these errors are due to internal communication failure. You will agree with me, where we don't communicate with each other, we don't report, we don't listen, we don't document, we don't communicate with the patient, and these kind of errors happen, keep happening, and we don't take any corrective or preventive action to work on them. You have seen this slide earlier also, I believe, that 60 to 70% of these errors are because of poor communication. If we can look after the communication part, I think these things can be definitely controlled. So although the guideline says that all harmful errors must be disclosed to the patient, but a number of studies suggest that we are less inclined to report and disclose the errors. I think you'll agree with me. You are seeing it day in, day out in your workplace situations. Studies suggest that 2/3 of the errors are not reported. Even if disclosure happens, it never meets the patient's expectations. I was reading a study, the quality analysis of disclosure, according to the physician's rating, it was 8. And according to the patient, it was 4. So you can well imagine the gap between their expectation and their actual deliverance. And also we know that trainees are often not, taught, or they don't learn to disclose. So if you have not learned anything, how can you really do it effectively? That's the question, we need to ask. But the problem is when errors like, wrong medication, wrong patient, wrong size surgery, these are errors that cannot be hidden. They're bound to get known. Come right on your face. So that's where you really need to communicate with the patient and the family. And therefore we need to be ready in how do you go about disclosing these errors. Although we know this is probably one of the most undesirable and difficult communication. But even if we don't want, if we need to do, we need to do. And therefore we should know what is the right way of doing it. So before we actually do the understand what is the protocol, let's do a small activity. The activity is, we'll take up this case where this patient was admitted in the hospital, and he had multiple injuries after a car accident. And he also had a deep cut on the left arm that needed to be sutured. But your resident and your staff nurse, put him for surgery for a broken leg. Now the family has got to know, and they want you to explain what has happened and why things went wrong. So maybe what we'll say, you can take a picture of this case if you want, because you will need this information when you will be doing the role play. Done? Okay. So I'll be again sending two of you to the breakout room, like in pairs I'll be sending you. But I'll give you 10 minutes time this time, because I want both the parties to play the role of a doctor, so that each one of you get to see how do you really handle that situation and how do you really communicate. It's very, very difficult. And I would expect if the patient's family, let it not be patient, let it be the patient's family member whom you're interacting with. Let the patient's family behave the way you would normally expect the family to behave. Not like, okay, it's all right, you haven't done it deliberately. Let him or her be aggressive, so that you get to see how do you really handle that aggression and how do you calm them down. So I'm making.
Ma'am, can you please share the slide once more?
Once again?
Yes, ma'am.
Okay, sure. You can take a picture. Done?
Yes.
Okay, thank you. Okay, so I'm going to now move you to breakout room, and the time that you get is 10 minutes okay, or you want me to give 15 minutes? 10 minutes are okay, fine.
Okay.
Do you want to say something? Okay, I thought you want to say something about. Poonam, you need to join Renuka. You got a message. Yeah, you got a message to join. So you need to Renuka, yeah.
Okay.
Room number 2. Your room number 2.
Within,
So how did it go?
So, ma'am, as ever, I was the most difficult, I'm sure, the patient relative. And always you put me up with Samira ma'am, and Samira ma'am says, oh no, not again. Again,
No, it's
Sandhana will
not
come.
me.
It's again going to create a havoc.
So it's
Yes,
not
we have
me.
seen the role play.
It's not me. It is the Zoom that picks both of you together. So maybe.
Okay.
So that's what I was telling Samira ma'am. Either I have to come and stay with you, or you will have to come down to India. Most welcome, with open arms.
Oh yes, Dr. Santuna is very hospitable. Let me tell you, she's very hospitable. So you will enjoy her company.
Yes, I know. But she was exaggerating.
This is the kind of patients we are handling here. So maybe
she,
that's.
she make me afraid.
In between, Samira ma'am was laughing. I said, I don't know what to do now.
Okay, so let me quickly share the screen with you and then ask you a couple of questions that you should be asking your participants. So we are doing double the task. So we need to, know what questions we need to ask to our participants. So my first question to the person who was, playing the role of the doctor, to you, I wish to ask, what do you think you did effectively? So if, couple of you could tell quickly what you think you did effectively, that will give us an idea. What are we really, good at or okay at?
Ma'am, I briefed Samira ji on what is the patient condition and what exactly happened during the entire process, and how the patient is safe and would recover quickly, and we would be responsible for his entire stay and all.
Okay. What about others?
Accepted the mistake, what has happened,
Okay.
and reassurance to the family members
Very good.
that nothing very difficult thing has happened. We will manage the case and it will be taken care by the hospital and hospital team.
Wonderful. So thankfully, whatever the situation was, it was not that bad that it cannot be, undone,
Mended.
or it has
Undone.
any permanent damage to the patient. For example, it was a case of amputation of the wrong side. Then it would have been very, very different situation. I completely agree with you. Okay, what about others? Anything else you think you said you did differently?
Yes, ma'am. In our case also, as a doctor, I accepted the error made by us, and I explained her the entire situation. How did it go wrong? And took the accountability as the head of the hospital, and also offered her the error has been made, but the real problem has also been treated. He is safe and sound and is kept in ICU for observation, and the whole expense the hospital is going to take care.
Wonderful. So all of you, if you see, you're coming up with different points, but you could have seen the impact of what you said to your client and how it must have really affected your, conversation with the patient. Anything else that you did differently? I'm getting good points from all of you, so I want to ask more to all others. Gurleen, do you think you said something or did something that you felt was really good and it helped you control the situation or manage it well?
Ma'am, I started with admitting the mistake. There was a human error, and then I empathized. Of course, in this case, I assured them that the patient we'll restore we'll look after the patient medically and ensure that they're compensated as well for the suffering that the family's gone through. And then I promised them an immediate solution, which I think helped them calm them down. Yes.
Wonderful. Excellent. So you use the word empathy. So you empathized and you also assured that we will take proper care of your patient, and also whatever is required will be done in your patient care. Very good.
Empathy, ma'am. Even I said, I can imagine and understand, had it been with me, Even, and then the caretaker asked me what you would have gone through. I said anger, wild anger and aggression. I mean, I can get you. And I said,
So
we
even
apologize
validating
to.
anger. So this is validation. See, what you have done is validation. So validation
Yes.
does not mean that we are encouraging the person to be angry. Validating actually gives the other person feeling that, okay, what I did was very normal, but I have to now think logically and move forward and not get stuck with the situation. Wonderful. I think this was another important, good input from all of you. Dr. Hemant, anything you did effectively or differently that you think you can add here?
Ma'am, I played the role of aggrieved attendant, brother of the patient.
Okay.
I demanded for the waiving of the fees first of all.
No, Dr. Hemant, wait, hold on. So right now I'm asking in case if you played the role of the attending doctor, then I want you to give your input here, because right now we are focusing on, as a doctor, what you did differently that you think would help you in controlling the situation. So did you play the role of the doctor?
I played the role of patient's
So you didn't change the role later on, because I had asked.
Actually, we consumed the time in that negotiation and thing.
That's okay. That's okay. So we'll come to you once again when I will ask you as an attendant what you felt and what you think did well. But okay. Anybody else who played the role of the doctor and has something to add to this? But you know, all of you have given such good points that actually is part of the protocol. And if all these points are collected and implemented when you're actually handling the situation, you can handle any situation in that case. We'll be talking about it a little later. So how did it feel to be doing this, to be in the doctor's chair? How did it feel?
Bad, incompetent.
And that realization?
Yes.
Helplessness.
We know it is bad. We know it is wrong. So it's like not justified in any account. So whatever you try to convey in a calm, empathetic,
even if
you know it is wrong. Matlab galat hai.
Happen. Even if you are responsible for it. Therefore, now there's a term very often being used in the healthcare, second victim. I don't know how many of you are familiar with this term, second victim. So the healthcare provider who has made a mistake, one second, I need to, sorry, it was a call from my friend, so I need to, So what I'm trying to say here, the term second victim is now being, talked a lot about. The person who has made a mistake is also victim of the situation. We normally assume mistakes are done because of the carelessness of the person, which is not true. It may be a negligence, but it is not carelessness. It is usually it is either because of being forgetful or tired or preoccupied or multitasking or anything. But it is not a deliberately committed error in the patient care. So now the concept of second victim is being talked a lot in healthcare, because we cannot be punishing the person who has made a mistake. And we got to really work on it. And I really recommend all of you to read a book called Complications by Dr. Atul Gawande. Beautiful book, must read if you want to see the doctor's side of the situation. And not that he is justifying the doctor's errors, but he's trying to bring up how people make mistake and then where do they ultimately land up. It's a must read. You must read that book, Complications. Very beautiful book. So that means
I recently got his checklist manifesto. I think add on this also to my list.
That's a beautiful book. Checklist Manifesto is a wonderful book, especially when you are into quality implementation. You get wonderful ideas. How do you go about, creating checklists for various areas, and how it is helpful in ensuring, things happen in proper order. So true. Yeah. So I think doing this, you must have realized how difficult it is to be on the other side. Even when you are a giver of the news, it is not easy. It is not, convenient or comfortable. Then what were your concerns if it was a real life case? What do you think would have been your concerns at the back of your mind? What would be running?
In fact, Samira ma'am discussed a live case with me, what she had experienced.
Okay.
And I was acting as a patient's sister.
Okay.
So how she managed it and how they discussed was like ma'am had very well, I think so. She very comfortably and empathetically she discussed about it and how the case was handled.
Wonderful. Wonderful. That's because maybe, you know, once you are experienced, you can still do it in an effective manner. The problem is when it is a naive doctor or a new doctor or a not very experienced doctor, challenge is there you are not able to handle this situation amicably. So if it was a real life case, what would have been your concerns or the hindsight, thoughts?
I think I kept thinking that my license could be revoked and subsequently I could lose all the reputation.
Reputation, yeah, as a doctor, you know.
Yeah.
So we are a lot worried about our social reputation, professional reputation. Of course, legal action, like you said, my
Legal
license
actions.
will be revoked,
Yes, ma'am.
or I may be legally, considered, punished for that. And in Western countries, it is mainly they have to pay a heavy amount to the patient as a compensation. So of course, even in India, that's now a trend, and we also know now lawyers are kind of working hand in glove with patients and instigating them to litigate doctors to either waive off the expenditure or waive or get money from the doctors or the hospital as a compensation. So we do get to hear these kind of news also, and we all know. But at the same time, I think, what other concerns do you think you had? Dr. Samira, if you would like to share your thoughts about it.
Of course, we will be afraid before we speak because you don't know the response of the patient.
Correct.
Maybe unexpected.
Yeah.
So it is very difficult.
Yeah.
Really.
So we don't know how the family might react. They may become aggressive. They may fight. They may start hitting us. They may start breaking things, or they may call police, and there can be legal action. And all these are, imagine something has gone wrong. You need to inform the family, and then you are overwhelmed with these thoughts and feelings. So how confusing and overwhelming it can be for anybody who is in that situation. I think we could get to see that just with this small role play. And what skills do you think would help you in dealing with situation like this? If we have now talked a lot about what you did effectively, can you quickly think of a couple of skills that can help the attending doctor to do it more effectively? Yeah, Dr. Samira, do you want to say something about it?
Yes, as the same skills of dealing with angry patient, empathy, acknowledgement. Yes, listening, attentive listening to their talking about what they want, what's their request. Yes.
Yeah. So it's almost like breaking bad news. You are breaking a bad news that we discussed last time. So the same skills, I think, are required. You need to be listening. You should be understanding. You should be empathizing. You should allow them to speak. You should listen to them attentively. Also check their concerns, address their concerns, do whatever you can do to help them. So all those skills will definitely compassionate, and also, like, one question that one statement all of you made was, okay, hospital will look after your care or damages or the financial part, but honestly tell me, how many hospitals are really willing to do that? And that's probably the biggest reason of conflict between the patient party, that you have done the damage, you still want us to pay for the overstay or the surgery or the corrective procedure. Then, like that, naturally, then that's where they get aggrieved and they move towards litigation. I was reading another study, where they rigorously focused on 3 points. One is they implemented disclosure policy. Second is they said fairly and quickly compensating the patient party, and saving the time and not like prolonging it for too long. And even the cases where the hospital says there is no merit, aggressively working for those cases so that they are given, fair treatment, and also, making sure that whatever errors are identified in future, what can be done to minimize those errors. So, and they really saw a drastic change in the errors that were happening in their institution. So the institutions have a very big role to play. Of course, we'll be talking about it, towards the end. Now, and what was the takeaway from this role play that you did? Quickly, or maybe if you want to write in the chat quickly, if all of you can write one point. What is your takeaway from the role play? Write in the chat. So I think even if we have one takeaway, that it's not easy, it's a very difficult task. Anybody who is in that chair is really struggling. And even if that person is not able to do it rightly, not that he or she doesn't want to do it, maybe the person is so overwhelmed that he's not able to really handle it effectively. Even that empathy for the person is also can be a good takeaway from this role play. Very important to inform it firsthand and address the issue. Yes, that's very important. Yeah, if you can tell it yourself, it's better than your staff going and telling, or anybody else going and sharing. A lot of time your staff will go and share with the family that this is what has happened in the OT or in the labor room or in the ICU. So then again, ultimately you have to come out with the reality or with the fact. Okay, so quickly now moving to the patient party or the observer who was like attendant, you can say. So what do you think attending doctor did effectively? Now, those who played the role of the patient's family, quickly share your thoughts. Yes, Dr. Samira, please.
Yes, I noticed that she was so confident while she was speaking with me, and so it has a much effect on my feel. Yeah, I felt that there's it's not intention. It is this fault is didn't done intentionally, and she was apologizing and almost always ensuring that he will be okay. Nothing will happen in future regarding his health. Yes.
Wonderful. Excellent. Wonderful. Thank you. Thank you. Anybody else who would like to
I think what Dr. Gurleen has done good was she has not wasted time in telling the reasons. So most of the time it is very annoying to the patient. It has happened. Now you whatever you do, you tell 100 reasons why you are worked out or something.
Yeah.
At that time, nothing will go into their head.
Yeah.
Their only concern is like what can I do, and to convey it to the management where if the financial this thing is short.
Yeah.
So just, if this time is gone, then things will not be taken care of.
Yeah.
So she was very good at acceptance and care providing and composed and accepting the error. That was very good.
So that means we realize that if you admit it, it's better. It's always helpful to calm the patient and also, bring the patient to the table where you can actually negotiate and talk what needs to be done and how you need to now, take it forward. Wonderful. Any other input from anybody else? What you think your partner did well as a doctor?
Ma'am, Samira ma'am had given her live example about what happened with her case. Okay. And how she managed it. And the best part was that the first part of hers was assurance that the patient is fine, the baby is fine. It was on a C-section. And then she discussed. So the positive thing was already there in my mind as a patient relative, that everything good is happening. And then she very slowly put it up subtly that there was a small mistake in the equipment and so things happened, but we will take care of it. And when I started becoming a bit agitated, she said that they will call the expert also to ensure that all these things are managed effectively.
Wonderful.
So that way she did a very excellent job, ma'am.
Wonderful, wonderful, excellent, wonderful. So being patient's attendant, how did it feel? Because we are mostly on the other side. But I'm
So
sure
I was quite confident.
Yeah, no, but how did it feel to be there? Suppose if you are attendant to a patient who had some mismanagement. So how do you feel?
No, so I definitely was upset, and my concern was that why did such a thing happen?
Yeah.
And I was quite furious. And if it would have happened with me, actually in this thing, it would have been even more aggressive way of approach. And because there are things which we, as a patient relative, if I am a layman, I would always feel that I have come here with the trust that nothing is wrong is going to happen to my patient, and if anything goes wrong, then it is the responsibility of everybody in that hospital, right from the security to the CEO of the organization.
So Renuka, how did you feel to be in the patient's chair?
Agitated for a change. I was angry. Because I had to put myself in that shoes. But I can tell you, Poonamji handled it in a very nice way, and she gave that assurance, and that everything will be taken care of from the hospital side. I did say that we'll go to the papers, we'll go to the court and all that. You have to, that we have lawyers and all. But she handled it in a very calm way.
She managed it. So that means,
another thing, what is key? One thing is key. What has happened? Now another thing is the patient's. What is the loss actually?
Yeah.
In my case, I told he was a sportsman. So you have, and he was a budding athlete and this thing, and you have spoiled whole career of it.
Oh, yeah.
So when the courts take into account, they take how much you have spoiled his career. Age of the patient also is also that kind of thing.
Exactly. I completely agree with you. So as a family member, what are major concerns a family would have?
Ma'am, if the person is the sole breadwinner of the family, and if something like happens like to the limbs or something, and he was into that kind of business where without mobility his things are cannot be done. So it's a very grave. One thing is that medical error is there, so they are ready to part with it. Another thing is that how will they run their house?
So, ma'am, as a patient relative, I would think about the impact of the or the outcome in a short run and a long run on the patient and the patient's future, whatever it is.
So that means immediate concerns are whether the patient is safe or not. That's probably the first.
Yeah,
second could be expenditure. Third could be what will be the life after we are out of the hospital. Will he or she be able to work, as usual, earn as usual, lead the same life? So that becomes the primary concerns of the patient's family member.
And how long?
How long?
Like, how long? 6 months, 1 year? How long the patient would not be able to work and come back to the normal life?
One of the things was hand is somewhere, leg is somewhere. So, that's a blunder can happen. Then
it's
unsafe to be in this kind of a place. So how fast we can come out of that hospital?
Exactly.
So one of the major concerns of the family.
So I think it gave us some idea about how it feels to be in the patient's chair, and also when you sit into the doctor's chair and do the same role play, even that must have given you an insight that it's not easy and it's very, very difficult for anybody to be there. So I think similarly, when you were observing, you did observe all these things. So I'm not going back to this. We have discussed it. So question is, what do patients think? Studies suggest they normally conceive the errors broadly. Can you mute your device? I think somebody's device is, yeah. Thank you. Yeah. So the first thing is, some of the studies suggest that patients actually conceive errors broadly. They don't go into the minor, details, but they conceive it more, in a broader sense. That means surgery went well or not. What exactly went wrong? That's not the thing. So usually they'll say surgery has gone wrong, even if it's a minor thing. So they will say it has gone wrong. Or if it is, even if it is a major, even then they'll say it has gone wrong. So they normally conceive the errors broadly and not like the finer details of it. And also, patients desire full disclosure of harmful errors. So whatever has happened, they want to know the truth. They want to understand what exactly happened. They also worry that the healthcare worker might hide. So you will see them very often, trying to get more information from other people. So they'll try to sneak in and talk to the nurse on duty, or the cleaning staff, or the support staff, or the security staff, and they'll try to investigate from them and try to find out more information, because they always worry that the healthcare worker might hide errors. So the information that they want is basically, first of all, that the statement that the error has occurred. And you all have seen, the moment you admitted that yes, error has occurred, the patient party becomes at least satisfied that you are admitting, you are not denying. Whereas we have a tendency to deny. So there again, there's a conflict between the patient party and us. Second thing is, they want to know what exactly happened. So if you are able to clearly say it was equipment failure, or it was a procedural failure, or it was a documented complication that happens in such and such cases, so that means they exactly get to see where the things went wrong. Then they want to understand what is the implication to their health. Like we discussed, will I be able to walk again? Will I be able to run again? Will I be able to do my things? So all these things are on their mind, and they want to understand what is the implication to their health. Also, they want to know why it happened. So if you can give them a reason why it happened, even if it is done by you, I think they would accept it ultimately. And in this case, your previous rapport building will come handy. If your overall impression on the patient is that you are a careful healthcare provider, you are very meticulously working, you are concerned, compassionate, that's where they will not even then blame you or find fault with you, because they believe that you haven't done anything deliberately, but this is just a matter of chance that happened with them. Also, they want to know how will reoccurrence be prevented. So they may always say, oh, this has happened with us, I'm sure it must have happened earlier also, and this will happen in future also. So that means they want to know what steps are we ready to take to prevent reoccurrence of this kind of instance. And then, as I said, apology. And usually when we talk about apology, not many of us are happy to offer apology. We say it's not my fault. Apology is not about my fault. Apology is that this has happened to you and I feel bad for you. Even that's also a meaning of apology. So apology does not mean that I am taking the responsibility of what has happened. For example, if it's a known post-surgical complication or surgical complication, so even then you say, I'm so sorry to tell you this has happened with you. This was not expected. So not that I am taking the responsibility that I have done this to you, but this is something that I'm feeling bad for what has happened to you, and you are facing this situation. So this is one of the study that I was reading. I got to see this, that this is what patients normally think. Now, looking at the clinician's perspective, as very rightly many of you said, that it's not easy, because we know that it leads to a lot of embarrassment. Then there's a possibility of aggressive reaction, risk of litigation. We all know the moment you admit, you fear that there can be litigation, I can be behind the bars, my license can be revoked, or I may be given a financial penalty to compensate the patient. So keeping all these things in the mind, the focus is usually on the covering the errors. I think that's what we see normally. Whereas clinician attitude about error is that they actually define the errors very narrowly. Specifically, this has happened, this is what happened. So they would not be talking about the broad, but the narrow or the specific error that has happened. Of course, they normally agree in principle with full disclosure. They say, yes, it should be done. But again, how many of them are ready to do? That's a question to be asked. They want to be truthful, but then experience barrier in disclosure, because there are a number of reasons that stop them from disclosing to the patient or the family. Fear of litigation is one we have talked. lack of confidence in communication skills, like Dr. Samira said, that the people lack language, people lack communication, people do not know how to, handle patients' emotion. Then there is lack of institutional support. Usually, if any, anybody makes a mistake, the institution also draws their, support, and they punish the person who has committed the mistake. Now, we have also seen very seasoned doctors also find it very uncomfortable and distressing to communicate these medical errors. Not that it comes with experience. I think anybody and everybody who will be in that position would momentarily be very, very uncomfortable and find it distressing. What are the barriers? We have talked most of them. Let's see if there's anything that we have missed. Of course, there's fear of retribution from the patient, retribution from the colleagues or peers, fear of financial judgment, fear of legal action, fear of having to handle patients' emotions because we are not used to that. Also, there's a belief that some of us believe that disclosure is unnecessary, and especially if it has not harmed the patient. If the incident has not harmed the patient, we think there's no need to disclose and create more confusion. And some of us also believe that disclosure is primarily a factual conversation and not a complex interpersonal conversation. Whereas I'm sure you must have experienced through this role play that it is actually a lot of interpersonal conversation. It's not just about sharing, okay, this thing has happened to your patient, but there are a lot of dynamics and emotions involved in saying this and also receiving this. Then there are also beliefs that outcome is not related to the action on the part of the person who is disclosing. So somebody might say, what can I do? It had to happen. I didn't do it. If machine went wrong, what can I do about it? So when you make such statement, probably you're coming out of the mindset that it wasn't my fault. Even if it was not your fault, but it happened when you were managing. So somewhere maybe some preventive action that should have been taken, maybe maintaining the machine or checking the machine. Some error happened somewhere that led to this kind of an incident. Okay. Fortunately, most negligent cases do not sue. Studies suggest only 3% of the cases actually sue the hospitals or the doctors. But in spite of that, you can see how fearful we are of the litigation problem or the legal problem that we are likely to face. Now, why do patients sue? You'll be surprised to know that in 2/3 of the cases where the patient actually sued the doctors, it was not for the negligence, but it was because of the ineffective communication. Patients somewhere felt lack of empathy, and also they felt that there was probably withholding of essential information, that they were not given a true picture. They were actually given a very covered up kind of a picture. So there's a fear or a thought process that there is complete information has not been shared with me. So I have been cheated. So I want to take you to court to teach you a lesson. And lack of empathy is mostly the underlying emotion they experience against the hospital and the doctors. Now, coming to the point, how do you really go about doing it? So very quickly, I'm going to share these guidelines, whereas most of it you have already covered through your discussion. First of all, begin by stating that there has been an error. It's always a good idea to admit it. The moment you admit, the first argument that it happened or it did not happen is closed. The first argument is usually you will be saying it didn't happen, and the party will say this happened. So that question is automatically taken care of when you admit that, yes, this has happened by us. Then also describe the course of events using simple and non-technical language. Keep it as simple as non-technical as possible. They don't want to know you were doing it, you were puncturing it, and that's how where you actually punctured the artery, and that's why the patient bled. Even if you tell them, see, when we are operating, we're very careful, but then it's a blind procedure. There's a possibility of, puncturing the main artery. That's one of the documented surgical complication, and unfortunately, this is what happened. So you are using a very simple and non-technical language, and they understand it well. Also, if you can state the nature of the mistake, it could be a machine failure, it could be equipment failure, it could be anything, drug failure, its consequences, and also the corrective action that you took immediately to minimize the damage. Express personal regret and apologize. I think when you are able to express personal regret, they ultimately they feel that you are with them in their difficult time. You are understanding their plight. You are feeling sorry for what has happened with them. And that really brings down the anger and anguish against the healthcare providers. And over and above that, if you apologize, they have nothing more to tell you. Very rarely you will see, anybody going beyond it after you have done this. But most of the situations can be amicably handled if you are able to manage it. At the same time, you elicit their questions or concerns and address them. When you ask them, do you have any questions to ask, or do you have any concerns? So they may have some concerns, and if you can, we want to see the patient, we want to talk to the patient, can we meet the patient? So all these things can be, looked after amicably, and that would actually, calm them further. Explain the next step to minimize the damage to the patient and also CAPA for future. So if you can assure them that we have made a note of this and we are going to definitely work on it and make sure that such mistakes do not happen with any other patient. We are going to take a corrective action right away and preventive action to safeguard all other patients in future. That's what probably they are looking for. I think transparency and honesty is a very big virtue that you really need to demonstrate throughout your working. If you can ensure this, mostly they don't tout your intentions. The problem is when we do not build rapport, we are not very, open. We are not available to talk to them. We are not addressing their concern, and we are not transparent in our approach. That's where they doubt our intention and they question our intentions. So at the institutional level, a lot needs to be done. I think disclosure, patient safety, risk management, this has to be part of the patient management. I think we really need to integrate it in all our endeavors in patient care. Establish disclosure support system. That means somebody who has done a mistake should be able to come out with it. Unless they disclose, you will really face more challenges. So how do you do it? Provide background disclosure education. I think everybody needs training to handle this situation, right from the nurse to the lab technician, to the doctor, to the surgeon, to everybody and anybody who's involved in patient care is likely to make mistake and should know how do you really go about disclosing your error. Then ensure that disclosure coaching is done time to time, because new staff would be entering your setup. They need to be, again trained on how do you go about disclosing. Provide emotional support to the healthcare providers also, because ultimately they are also human beings. Most of the errors happen because of fatigue, overwork, preoccupation, multitasking, time constraint, failure on system failure. So and also punishing them at that point is not going to take you anywhere. Create a culture of patient safety where everybody values patient safety. Create a culture of employee safety where you make sure that employees are also, looked after and they feel safe working in your environment. Also create a culture where people report errors promptly without the fear of repercussions. Usually people hide errors fearing that they will be punished for the error. If you can ensure that you are not going to punish the person who reports, you will get a lot of staff coming up with the errors that they make, and you will get an opportunity to make, take corrective action and preventive action for future. And also, whatever disclosure policy you are implementing, use some performance improvement tool to track and enhance disclosure. So not that, okay, we have taught people to disclose and let them do it. Observe their disclosure and evaluate, are they doing it well? What more input they require and how they can, make it better. With this, we come to the last slide. I have two beautiful videos to share with you. Very beautiful videos to share with you. They are done by Indian doctors. All of you may be knowing Dr. Badri and Dr. Kingsley. I don't know if you know them. You know them. So they have done a beautiful video on disclosure of medical error. Give me a second to identify where it is, because I think I had kept it ready. Give me a second. Yeah. And after the video, I think we will have a discussion. Just 1 second. So I'll be showing you first the bad disclosure, and then we'll have a discussion. Okay.
Who's with Mrs. Kumar? I'm Mr. Kumar. Yes, hello. I remember meeting you earlier in the OPD. This is Mr. Girish, my brother-in-law. Hello. Please sit down. There are a few things I'd like to discuss with you about the operation. I'm afraid I have some bad news. We ran into some complications early into the surgery and we've had to shift Mrs. Kumar into the ICU. What happened? What complication? Oh no. Is she going to be all right? Well, she lost a lot of blood during the surgery and we couldn't realize where the bleeding was coming from. So we've had to open her up and it took us some time to find where she was bleeding from. In the meantime, her blood pressure was low and we've had to give her a lot of blood. Finally, we managed to control the bleeding. This was supposed to be a simple, routine operation. How can this happen? Well, Mr. Kumar, you remember the 1% bleeding complication risk that we spoke about? Unfortunately, Mrs. Kumar has had bleeding. We're doing everything we can to help her. We're giving her blood and IV fluids to support her. So now we have given the blood and bleeding is fixed. She's going to be okay, right? Well, she's lost a lot of blood and her blood pressure was low. So we don't know how long she'll take to recover. We'll just have to wait and see, watch how she does. What do you mean? Well, we just have to wait and see how she does. She's going to be okay, right? When can we see her? The ICU doctors are working hard to stabilize her. At the moment, she's not stable, so you can't see her, but we'll let you know. When she's stable, you'll be allowed to see her. I don't understand. This is supposed to be a simple procedure.
Okay. So we have discussed the protocol of disclosing the error, and also we have discussed breaking bad news. I hope you remember both the topics that we have discussed. So what do you think, what all was not right that this doctor did in disclosing the...
His monotonous approach, I mean,
Okay.
he just put it forth without...
Or like, reading the news for the patient. Just
It was like point blank, he came to the conclusion that this and this has happened and the patient is there and they are not ready to take any responsibility on what is going to happen in future.
True.
And moreover, he talked about that 1%, like he's reminding them that yes, you had agreed to that clause. So this 1% is you.
Rarest of rare case.
Yes.
So if you will look at the situation, it's not an error actually. It's a documented surgical complication. So, but even if it is a documented complication, But imagine the family who is facing it and whose family member is in the ICU. So what do you say, Dr. Samira? What do you think was not done right?
Yes, he was not apologizing, not empathic with them at all. And he left them. He didn't listen to their concerns at all.
He did not listen. He did not let the attendant complete their statement, if you observed, he just walked away.
Yes.
That shows either he was in hurry, or he was scared of the situation, or he was avoiding. It could be anything. But then he left the conversation in between. He did not leave them satisfied. What else, Dr. Hemant?
No reassurance.
No reassurance. Absolutely no reassurance.
No empathy, no compassion, no.
Also, no lack. Also, I mean, there was lack of accountability.
Lack of accountability. Very right. One more observation that I want to bring your attention to is when there are two people, it's always good to engage with both of them. If you talk to one person and ignore the other one, the risk is this person will be agitated, to whom you are ignoring. Now, this person can instigate this person to argue and fight with you. So it's always good to address both the parties. At the same time, you will, if there are a lot of people, say 10, 15 of them, and you need to segregate because you can't talk to all 10, 15 of them at one go. So at that time, it is always good to take in somebody who is actually nodding when you are saying something. So when that person is nodding, it is showing that this person is more or less agreeing with you or is understanding your point of view. So this person will be of great help to you when you will take this person in to talk about the problem. So of course, it should never be done in an open area. If you saw in this, he was doing in the lobby. There were others sitting outside. So there's a risk of others overhearing, and your behavior gets altered. Family's behavior also gets altered. They may get support from the mob and then they become aggressive with you. There's a risk of assault also when you do it in an open place. Yes, Dr. Hemant.
Ma'am, this was the one point which I also wanted to mention. The place of disclosure is very important.
Yes.
So we should use those areas. And secondary thing, after that thing happens, we should know who is primary attendant.
Yes.
So generally what happens, they call the attendant who are there, and they won't understand and they have not been touched. So primary attendant is must. And another thing is generally people do to shun away the other this thing who are accompanying. If they question in between, okay, I am not answerable to you all.
Yeah. Who are you?
Just
who are you? Why are you here? You go out. I'm talking to the patient's attendant. So again, you're calling for problem. You're calling for problem.
Yes.
So Dr. Samira, how is this similar to your setup?
Ma'am,
Please.
Sorry.
Yeah.
Ma'am, one more thing. If something like this happens, so the family is more concerned about the patient at that time. So if you can give a definite this thing, okay, come on, I'll show you. She's fine now. You can see her. So or I'm going to see that it happens that within short span of time I'm going to update about status, or I will personally touch about and keep on updating you. So that kind of things will sort it out.
Completely agree. I completely agree. So Dr. Samira, I was asking you, how is it similar to your setup?
Yes, if the healthcare provider are not trained, they will behave like this. Exactly.
But are they trained? Are they usually trained?
No training.
No, I think that's the problem. And everybody does the way they like. Some of them are really good at it, but not all of them. And just one case is enough to spoil the whole situation.
Yes, it depends on the personality of that care provider.
Yes.
For example, me, I didn't take any training really. But when I talk with them, they accepted.
Yeah. Very true. I completely agree with you. I think it has a lot to do with the personality and the training that we receive as a doctor. If I'm trained to be authoritative or rude or aggressive with the patient, then I'm going to be aggressive in all spheres of life. And how much ever a training you give me, it won't help me, it won't work for me. And we know this with a lot of doctors, this happens. That's true. Yeah. Anybody else who would like to give any additional comment besides what we have discussed? Yes, Dr. Hemant, please.
Ma'am, the ideal thing is generally the people who are dealing in critical things, they are able to handle it much more better than a person who is just seeing on OPD basis generally.
Yes.
Because those kind of things happen after criticality doing something. So they as a team of doctors and they as a team handles more. So even they can be used and they can train others people. So
yes,
they know how critical patients attendants are and how something wrong happens. Or
yeah.
so
Because they are more
familiar.
familiar with this kind of situation. So they automatically get trained by doing. Yeah. And a lot of doctors in our country have come from NHS, UK. So they are really trained very well to handle these situations. So they have come back with a lot of training from UK, and they are, training our doctors, nurses, and other staff in these things.
And exposure, like in emergency, ICU, critical area, they get more exposure for all these things.
But we need more
comparison to
every area, because any area can have such situations.
Yes.
Moreover, ma'am, I feel that such situations should be handled by the senior member of the entire team rather than sending the junior doctors to discuss with. And it is very common, like, they just try to, okay, fine, you go and speak. Tell them. So they just try to put the buck on someone else. It should not happen like that. The person who's responsible for the team, the senior most person, should go speak and make the relatives understand what exactly is the scenario.
Exactly. And a lot of time, in the OT, the surgeon will say, ask anesthetist to go and announce. And there will be an argument on it. As anesthetist will say, you go and say, because you were operating, so you need to talk to the patient. And the surgeon will say, no, you go and, and sometimes there's a conflict on that also. So let us see the second video and see if it could have been done in this manner.
Who's with Mrs. Kumar? I'm Mr. Kumar. Hello, I'm Dr. John. I had met you earlier in the OPD. I don't believe I've met you. I'm Girish, his brother-in-law. Hi, Girish. I'm Dr. John. There are a few things that I would like to discuss with you about the surgery, but I would prefer that we do the discussion in a more private place. Is that okay with you? Okay. Please come. Unfortunately, I have some bad news to share. We've run into some complications into the surgery, and we've had to shift Mrs. Kumar to the ICU. What happened? What complications? Oh no, is she going to be all right? I understand that this is not news that you expected to hear, and I'm very sorry about this. There is a lot of information that we have to share with you, and please feel free to stop me if I'm going too fast or if you need any clarifications. Now, Mrs. Kumar had some bleeding early on in the procedure, and we did not exactly find out where the bleeding was coming from. That's the reason we had to open her up, and it took us a long time to find where she was bleeding from. In the meantime, she lost a lot of blood and her blood pressure was low. And eventually, we did manage to find the blood bleeding point, and then we thought we have to shift her to the ICU to monitor her blood pressure. But this was supposed to be a simple operation. How could this happen? Well, in order to do this operation, we first have to put a needle into the abdomen to build gas before we put the camera in. When I put the camera in, all I could see was blood. I could not see where the bleeding was coming from. And that's the reason I decided to open her up. Where did that blood come from? The bleeding was coming from a major artery inside the abdomen, and it appears that the initial needle insertion was responsible for the bleeding. Who put that needle? I put the needle in, and I'm very, very sorry about it. This just was not expected. We are trying our best to minimize the effects of the bleeding. Is she going to be okay? I wish I could tell you, but it's too early. I just don't know. I certainly hope so. She is on life support medications right now, life support systems for breathing. She is getting blood to keep her blood pressure up and powerful medications to keep her blood pressure up. We're doing all we can. When can we see her? Well, the ICU doctors are working hard to stabilize her, and as soon as she's stable, you could see her. I will let you know. Do you have any questions for me? Really don't know what to say here. I can understand that. If there are any questions, please don't hesitate to ask. In the meantime, I'm going back to the ICU. I will keep you updated on her status. Is that okay?
So I hope that gave you some idea about how the whole thing could have been done more effectively. And if you look at the tone of voice, the voice that he expressed, the body language that he showed, the way he sat, although I know, I mean, we normally don't recommend sitting so close to the patient's party, but that's only when you are expecting some kind of, violence against you. But if you have been able to win their confidence and win their trust, I mean, even if they lose a family member, they will not still, kind of blame you for it or not physically assault you. Yes, Dr. Hemant, you want to say something?
Ma'am, generally when we deal patient and their attendants, we deal when everything is fine. So,
Yeah.
and human reactions are very varying. The loss and this thing are, you have never. So as a safer precaution, whenever going for such things, we need to inform security, let them don't be visible, but let them be approachable. So in case it happens, they can intervene because the reactions can be bad. And ma'am, another thing, after the whole conversation, this is my observation, ma'am.
Yeah.
Because at that time, we cannot end with you have got more questions, because that scenario is very distinct. They are not into that kind of a information about thing. Only you can say, and you want to close it down and then move on. So no more questions, because again they will think in spite of doing you are asking what else we should ask. So it doesn't work. At times it doesn't work.
Again, Dr. Hemant, this is just an idea to food for thought that how this can be done effectively. We can pick and choose whatever suits us. Like very rightly said by you, that we always prefer sitting across the table rather than sitting so close physically. Even when I do my trainings, I tell them very clearly, you should sit across the table. Like very rightly said by you, the moment you hear about death or complication or, patient's condition deteriorating, one might react very differently because we become completely, out of our mind for a second. So that possibility is there, and I agree. Therefore, we say ensure your safety. And very rightly said by you that we should always have security on our hand, but they should not be visible, because if they are visible, that further instigates the patient party that okay, you have already called these people to hold us or to hit us. So that can aggravate situation. But I agree, doctor safety is equally important, and preferably it should be at least there be 2-3 people around you rather than you going alone and doing it. They may not say anything, but they can be around to, in case if need, they can control the situation. All those safety precautions will have to take, accordingly. Yeah. So with this, I think we formally close this topic. But in case if you have anything to share or ask or give feedback about the videos or the discussion we had till now.
Ma'am, this was pretty good, because generally what happens, ma'am, we see Western videos. So the Indian emotions are, we can relate, you know, the body language, how we feel, and the immediate reaction of husband or close family member. So very well done in that video, ma'am.
Yeah, they are extremely seasoned doctors, those who played in this video, and they are wonderful trainer also. You know, they're excellent trainer, and that's what I said, that they have done their training with NHS. They have worked for NHS, and they have brought this training to the country. And like almost like 10 years ago, I got trained by them. And they keep telling me that you are the one who has taken it so forward. And we are very happy and proud of you.
I was one of the participants for the healthcare communication training by them in Nanavati Hospital a couple of years, 3 years back. And Dr. Badri had presented these videos at that time.
Yeah. They are excellent trainers. Both of them are excellent trainers. Wonderful trainers. Yeah. So good. So I'm also lucky to have been trained by them. Yeah. So any question about it before we move further? So I think Renuka is not feeling well. Renuka, I think you can, you can log out if you want. It's perfectly all right. We understand.
Thank you, ma'am. I'll catch up later. I'm unable.
We'll be sharing the YouTube recording, so you can.
Thank you, ma'am. Thanks. Bye. Bye.
Bye. Take care.
Take care, Dr. Renuka. Wishing you speedy recovery.
Yeah. And we'll be meeting next week, no? So we'll be.
Yes, ma'am. Thank
you. Take care. Bye. Good night. Good night. So moving further with the presentation part now, we have two people to present today. One is Bindu and second Poonam. Will you present? Okay. So who would like to go first? Bindu? Okay. So Bindu will be presenting on a topic of reflective questioning.
Yeah, reflections.
Reflections. Yeah. Okay. Reflective questioning or reflections. And Poonam, what will you be covering?
Mine is introducing the topic in an interesting way. Just
okay. Wonderful. So go ahead, Bindu. So you have 15 minutes time. It is 9:45 exactly. So let's connect it. Let's have 15 minutes for you. Please go ahead. Yeah.
You make me the co-host.
Sure. Give me a second. Yeah. Sorry. What have I done? I made you.
Okay. In the beginning, I am showing a video, and on that basis, we'll go further.
Sure.
The video is about the hospital staff, the nursing staff, the others support staff, and
there is no sound to it, Bindu?
There is, but it's just music.
I'm not able to hear.
Give me a second.
Actually, this video we have seen earlier. I don't know if you were not there in that program or what, but we had used this video in one of the programs.
Yeah. Okay, I must.
That's all right. We can see it once again for you. But only thing is, with music, I think with the sound, it goes very well.
Let me try because I can hear the sound. Let me check.
So maybe your output is not connected with the.
It might be a technical issue.
All others are able to hear to the sound?
We saw this video previously at the beginning of the course.
No, audio is not there. Just the video.
You can't hear the audio.
No.
From my side, everything is plugged in.
Ma'am, no issues. We have already seen it.
So you can get the essence of it, I think.
Yeah.
Yes.
I'll. Do I need to play it? Or
yeah.
Give me a second. Play the video.
I don't think you need to play it once again. Do you want to play it once again, Bindu?
आप बताओ, as you people say.
We all have seen. We have seen this video.
Okay, so everyone is aware of it, na?
Yeah.
So after seeing the video, like Poonamji, what is the video is suggestive of?
Actually, I didn't.
Oh, Poonam, you had not seen it?
No, I have not seen properly actually.
Okay.
So maybe you can ask someone else the question.
Okay.
I'll respond to the next.
Through it? Can we
Yeah,
run
again.
it through quickly?
Yeah, I would also suggest that if you could just go through it so that even Poonamji is aware of what it is.
Yeah.
Okay.
And the audio if possible.
Poonamji, I'm trying for the audio.
Okay,
it's not working.
Bindu, let me play it for you.
Okay.
Yeah,
that would be fine. Yeah.
Give me
Perfect.
a second. Yeah, I'll play it for you. I have it with me.
Yes, the video, I mean, it's a clear-cut depiction of what human emotions are, what all inside stories are. I mean, be it hospital staff, personnel, patients, from doctors to attendants. I mean, everybody's inner story, outer stories have been depicted. And one major human value, human skill, empathy, has been focused on it. And I here today, my audience is the hospital staff, supposedly you all are. And my next question to Dr. Santvana is, ma'am, what have you noticed? What has been a significant observation by you through the video?
Ma'am, the most important thing which I see over here is basically the empathy each and every individual needs to have, whether it's the doctor or it's the healthcare worker, towards all the patient or the patient relatives who are coming in an organization.
And why would you?
Definitely, whenever anybody, many people have not seen this video, but whenever we show it in maybe in a group, in a hospital or in a healthcare setup, they would definitely start identifying and understanding the patient's mentality, what they are going through, and then start empathizing, and the behavior or the relationship or the communication skills with their patients would change.
And yes, Dr. Hemant, I can see you. Yes. So what do how do you perceive the healthcare system to be like this?
Very moving video. You see it 20 times, you'll feel that feeling that you are part of it. You have been part of it through your years. So one thing which I feel is key. It's not about only the healthcare professionals, the patients. It's about the patients, their attendants, seeing the perspective of what a healthcare person is also going through, uh, were rightly seen by a nursing staff or doctor waiting to end 12-hour shift. And there are moments, their personal life is in this thing, their marital status. There are a lot of things. So, in spite of that, they are putting their best and doing in, day out. So, that is also, it's like both ways. So, and it really shows those emotions, those things, and keeping these emotions under control and doing your duty and part. So that is also one thing which we should all take into account.
And Poonamji, on an introspection, I mean, where do you rate yourself? I mean, supposedly you are a hospital staff. Where do you see yourself?
I would rate myself. You mean 0 to 10 scale? You are saying how
No, let's not talk about scale. Let's not go that objectively. I mean, you have been working with the public health system.
Yeah.
And what situation have you seen? Does it happen like this?
Yeah.
It
in
does.
Most of the
in most and
yeah, people
places,
are under these emotions, like all healthcare workers, safety personals, and then patients, everybody. The situation is like this only.
And in case we think we take up few places where it is not like this, why would you want to make this change?
Or definitely for betterment. Like in government setup, we don't find this kind of an environment. It's really different. In people are always in a rush, hurriedly, worriedly, they are going here and there. Their empathy is missing, emotions are not taken care of well in other setups.
And Dr. Samira, to ask you, how might you go about it in order to succeed?
Well, it make our job more. We should not only focus on doing prescribing treatment and doing surgical operation. We should also think about those people as human being with their story. So it make us to behave like a human being, to help them as much as we can emotionally, and in addition to our job as a physician, doing procedures or prescribing treatment and so on.
And how would you take it further? How would you go about it?
Sorry, I didn't understand the question.
I mean, what techniques, what new innovations, what steps would you take to incorporate such a setting?
Yes, the training of the staff about empathy, about communication skills. Yes.
Okay. Anything else, Dr. Santhvana? Anything else? Ma'am, you are mute.
Sorry, I said this is fine. The reflections itself shows that even your picture, which is there on the screen right now, that itself shows that we need to understand the person in front's perspective, and how do we go ahead with it.
Okay. And Gurleen, can you point out some reasons to bring this change in our setup?
I think, ma'am, the reasons would be because when I was watching this video, like I couldn't help the first time around as well, and this time too, I just couldn't help myself, but I teared up. And I think it just made me personally realize that we have to be mindful of other people's challenges, their personal difficulties that they're struggling. And I think that realization in itself is one very compelling reason for me to bring about a change, to be more considerate of others, and especially in an environment where people are already struggling. They have everybody in that video had so many personal challenges of their own. I think as a health professional, the idea there is to support them holistically. And I think doing that to support them in every way through human connection, I think if that emotional coaching or support can be provided, it can.
Great. And Isha, how important is it for you to make this change? Isha, are you here?
Oh, yes, ma'am.
Are you in a situation to reply, Isha? Are you okay?
I will try. I can surely try. My mind is completely blank.
Never mind. Take care.
So we have Beauty with us. You can even,
okay, Beauty has joined?
Yes, she joined us, yeah.
Okay. Beauty, did you watch the video?
Are we talking about the Cleveland video?
Yeah.
I've watched it earlier.
Okay. And Beauty, this question goes for you. How important is it for you to make this change?
Make change in communication and behavior. Is that what we're talking about? In
In evoking
change.
human emotions like empathy, compassion.
I think more than evoking, addressing human emotions as they are and not ignoring them would be something more important and something that's really critical and challenging at the same time, because not everybody is good at handling emotions, and that's the weak point for all of us, not just for patients but for all of us. And learning to handle them, learning to identify emotions and being bold enough to uh, uh, identify and name those emotions, I think will come with a lot of practice. And once we are there, I think then communication is just, I mean, baएं हाथ का खेल. It'll become that
Right.
easy for
It
us.
becomes very spontaneous.
Yeah.
So this is, I mean, the main thing about reflective questions are they are not I statements, they are you questions. They are you. I mean, they are focused on you. It's your discretion. There is no, I mean, there is no ordering, there is no command in reflective questions. And what is the purpose of reflections? Anybody? Dr. Santvana, may I have it from you? What is the purpose of reflections?
Ma'am, basically the purpose for reflections is once you start empathizing, you become much more you can say connected to the patient or the patient relatives, and that helps building the confidence of the patient relatives with you as a clinician or as a healthcare worker.
Great. And anything else, Dr. Samira, besides connect and
Sorry, I didn't understand the question.
importance of such reflections?
Yes, it make us to know our defect and to improve it without anyone else telling us. So we can reach the what we are what are our weakness point and how we can improve them.
Okay. And Dr. Hemant, do you agree with these responses or you have some add-ons?
Ma'am, all views are very nice and with experiences, varied experience. And my take on is that one thing is there ki we are in a field, healthcare field, where in spite of your personal challenges, your personal issues, your personal grief, the moment you enter your zone and you have to put away, keep them into back burner or for a brief period or that duty period and go into that system because that should not be evident. So if you are going through a personal tragedy and that is witnessed on your face, then it is very difficult to get the patient's healing. So our primary objective is patient concern and our life, how we manage. So one thing is that, and secondary, ma'am, we have to understand the non-verbal things also because this is one of my observations. Like in critical areas or patients are pain. So we don't know. The staff doesn't know at times uh, their laughter in critical areas or having some fast food into that zone convey an attitude of casualness where you could have done it separately. So they don't know for the critical team it's a day routine affair. But as far as I see from a patient's perspective who is battling on life support, so that thing doesn't matches up. So these are the small things which I feel we need to look into things.
And Gurleen, how about you? Your input on this? Are you here, Gurleen?
Yes, ma'am. Ma'am, for me, reflection is it's actively thinking about my actions and thinking process and the intention to do that is to improve it for the future. So so it's a very structured.
You mean reflections, they at times act as reinforcers too?
Yes, I mean, I use it for my teaching. So I completely take notes where I'm able to analyze. It's a careful review, and then the intention behind it is it's to deliberately question and reflect on the action, the process, the technique, whatever it is. And the intention is to improve it, to learn, like we say, we learn from our mistakes and experiences. So we reflect on them, on how to improve things in the future.
So, Bindu, if you allow me to add a point here.
Ji.
So, what my understanding of reflections is something like seeing a movie once again in a slow mode.
True.
We all lead life in a very, very fast and, unmindful manner. A lot of things we do, not caring much about how it is impacting others, or, how it can be done differently. Reflections is a very good technique to help the audience to see their actions as a third person.
Yes.
When we saw this movie of empathy, this clipping of empathy, we got to see how the doctors, nurses, patients, and their family members are almost everybody suffering or going through some or the other personal challenge. So when we saw it one by one, we could understand that nobody is leading a very, comfortable and easy life. Although the grass on the other side always appears greener, and we assume that, okay, doctors are happy, nurses are happy, patients are happy, but that's not true.
That's not true. We all have inner stories.
I think reflection is a wonderful way to help people, peep through others' life and see how everybody is facing a challenge, and how we can make things easy for us and also for others by acting responsible and mindful. I think that's the purpose of using this pedagogy in any training program, and especially when we are working with adults, where we cannot straight away point out that this is what you do and this is not the right.
Yes, shoulds and musts can't be imposed, rather in the form of reflections only. So and as to conclude, I mean, whatever responses these, I have summarized them in these 3 points: strengthening relationship and foster trust, increased understanding of the person's dilemma, and giving an opportunity to the person to continue narrate his story as to self-explore. That gives time to the person to actually self-explore what exactly happened, how did it go, and how can I really work on it. Right.
Thank you so much. I think it was wonderful.
And another aspect, we have 2 minutes? I'll just...
Okay, you have something more to share. If you could go to the slide share mode, then we could read your slide. You are not on the slide share mode. So we are not able to,
Actually, this laptop is not working, and as I told you, I'm not well, so I could not do it on the other one. Actually, I'm isolating also.
Oh,
ma'am, you just have to enable the editing and then click on the screen share.
Click on enable editing. Your yellow line that you can see.
Where is it? I can't actually.
Ma'am, the yellow line of protected view.
You need to first share this. Acha, you've shared, no? On top, right above your title slide, right below the title slide, you see view, and then below that you see enable editing.
I don't know what's happened to my vision. I can't.
Ma'am, can you see where reflections is written? Just above reflections on the yellow line, you'll see enable editing.
This file originated
I can't
from an
even
internet.
see yellow from here.
Ma'am, I think
you can stop the share.
Bindu ma'am should get on with her. What is her point of view? Because she can share it later on to our group.
I would do that. I shall.
To move to that slide, automatically that slide will be visible in the smaller font. That's also okay.
Which slide, Indudi? I'm not getting.
You have 5-6 slides to show, no? You have.
Okay. This is the last. This is the second last. Can you see a slide right
No,
now?
touch that slide. You go and touch that slide.
Just give me a moment, please. I'll call my daughter. She has antibodies
No,
now.
it's okay. Then carry on. Bindu, it's okay. Carry on. We can see the presentation later also. You can send it to us.
Okay. Jyoti, एक बार दीदी को भेजना बेटा. How to this slide says about. I'm so sorry. आप लोग देख ही नहीं पा रहे हो slides.
No, we are still on the first slide, ma'am.
Ma'am, let's not. It was a very beautifully done presentation. So I think we should move on and let her ma'am send on WhatsApp.
Okay, this is about how to maximize the effect of reflections. And anyone can tell me how to maximize the effect of reflections, or if we are running out of time, I'll just conclude it.
Asking people to write the journal on their the way of functioning. So maybe, reflection can.
They cannot see my slides. Okay, now this yellow thing has come. Can you see now? Is it visible now?
But you have to write. Yeah, now it is. Resume slideshow.
Is it visible now? Okay.
If you could go to the second slide, ma'am, because
yeah, please. I would do that. This was purpose of reflections, and this was what I concluded.
No, we can't see anything.
Still?
Yeah, no. We are on the slide 1. So it's okay. It's okay.
Yeah, maybe I'll send it in the group in 10 minutes after the group. Okay.
So I think Bindu, you can conclude with the last comment.
Yes, to maximize the effect of reflections, some tips are giving undivided attention to the person, maintaining eye contact, and also mirroring the facial expressions. And besides putting reflective questions, reflective listening is an integral part of reflections. The person should feel that, yes, I am being heard 100%. It is not the person is pretending. The adequate facial expressions, the right timely done nodding, patting, they would all maximize the effect of reflections. And I'll just send the PPT in 10 minutes. I would take my daughter's help. She had been isolating and
no problem. That's all right. So thank you so much, Bindu. I think it was a wonderful presentation. We got to understand that this also can be used as one of the pedagogies in the training. It's a wonderful, So we are getting new ideas how to really integrate these things with our regular training programs. Thank you so much, Bindu. Thank you. So can we request Poonam to now make her presentation?
Yeah. See, I am the first timer doing this, so please.
Don't worry, we are all with you. We have
beautiful PPT for a first timer.
Yeah.
Just a minute.
Yeah. Yes. If you click once again,
yes, you can see my.
Yeah.
Is my screen visible?
Yes, it's visible. Yeah. So you can go to slideshow, no?
Yeah, I'll go to slideshow.
Don't go to the presenter mode. Presenter mode will give you like this.
Achha.
Straight away go to the
first slideshow.
Yeah.
Just a minute.
So you'll have to first end this slideshow, I think, because you'll have to come out of presenter mode. End the slideshow. Or she could even change the display settings, no? Yeah, that's good enough. Yeah. No, don't touch anything. No, no, don't go there. Just click the next slide. No, 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 no. Poonam, you have again gone to the presenter show, presenter view. Okay, go ahead with your presentation. Fine, go ahead. Yeah.
Now it's fine.
So that's okay. You are still on the presenter mode, but it's okay. We are okay with it. Go ahead.
You're okay with it?
Yeah.
Okay.
Yeah. Next one. Yeah.
So we all have learnt about learning styles. We all know that people are either auditory, visual, or kinesthetics. Let's look at a demo triggering the visuals in the house. I have a small creative game for everyone to indulge today. Let's see. Everyone can see a setting.
Yeah, we can see.
Set of images are there on the screen, right side and left side.
Yes.
I want you to interpret these images and come up with a word or a phrase by combining these two images. Don't hold yourself back. Think aloud. Whatever comes to your mind, it might help the group to reach the correct answer. Yes, yes, Mr.
Out of box short selection.
Okay, good, good.
Cricket box.
Cricket box.
Okay.
Next, anyone else? Binduji, Samira ma'am.
Raw material for both bat and the cardboard box is the same.
Yeah, good ideas.
Hitting box.
Which box?
Hitting box.
Okay. Gurleen, Bindu, Isha. Anything else? Chalo, let's see what it is. First picture depicts cricket match.
Oh.
Everyone agreed? Second one, cardboard box. So we can say matchbox.
Okay.
Interesting.
Matchbox. Okay. So something creative we have to start with the session.
Wonderful.
Great, sir. Let's do one more thing. Let's try another one. I'm sure now you all have a better understanding of what we are trying to achieve here. First one.
Ratrika Garba.
Angra.
Dance.
Close to that.
Glory.
दोनों को मिलाओ. First picture and second picture, you have to add both of them and try. कोई बात नहीं, थका हुआ दिमाग है, लेकिन still try.
Rangoli.
Yes, colors.
Folk dance and colors.
Yes, try. Chale?
Yeah, let's.
Folk dance is correct. Who said folk dance?
I said, yeah.
Achha, good. Let's see the next one. Art supplies, colors, pencils, and what the thing is? Folk art.
Folk art, yes.
Okay. My topic is introducing a topic in an interesting way. So we are doing that. Then comes the hygiene factor. Now I have to say hello. My name is Poonam, and we have been attending this wonderful course since the past 1 month. The course is all about communication and more. Here comes my first. I have introduced the topic in an interesting way. In any of the ways you can do it, and then this is called hygiene factor. Now the basic structure of a session will go on.
Karan Johar of introduction. What is that?
Let's see a video. Don't worry, this is not a typing error. We all should tweak everyday elements to make them work in our favor.
Great.
Let's see a video. This is one of my favorite examples. The class is high energy students. Let's see the video first.
It's not playing, Poonam. Is there some challenge?
Looks like internet, slow internet.
Yeah,
It says playing video. It says playing video below that. Hold on for us.
Video is not playing.
Go back and try again. Back arrow. Back arrow.
Back arrow. Okay.
Yeah.
Achha.
Try it once more. Try it once more.
Audio is there?
No.
Audio
No,
is also not there.
Video has not started.
As we know the audio part, the song.
But video?
No audio, no video.
No audio, no video. Okay. No audio, no video. Just a minute.
Chakaraka chicha cho chakaloram gando wando lakarakatam akko takko idi gidi gidi go idi pai chiki chakacho gili gili mal sulu sulu mal makanaka hukubukure tukubukure chakalaka bikko chikko sili 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 go bagradum chakradum chiki chakacho.
We were able to hear the audio was playing.
Yeah.
Actually, video should be there, then only.
I think it's okay. Maybe there is some compatibility issue when you're showing it in video, in the slide. Probably you have to have that HTML link to let the video play.
Okay.
So it's okay. Can we move?
You can see the video now? No.
No, it is not playing. The video is there, but it's more like pictures than video.
Achha, only pictures are there and no video.
Chakaraka chicha cho chakaloram gando wando lakarakatam akko takko idi gidi gidi go idi pai chiki chakacho gili gili mal sulu sulu.
Okay, we'll just then discuss.
Chakalaka bikko chikko sili 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 go bagradum chakradum chiki chakacho.
It was running, Poonam.
What? Video?
Yes.
Achha, video was there. I just wanted to show you for 30 seconds this video.
Okay.
The beginning. You could see 30 seconds video or no?
Yes, we could see.
Okay.
Yes.
Chakaraka chicha cho chakaloram gando.
Achha.
Okay, that was Karan Johar introduction.
Yeah.
Okay.
Many of you must have seen the movie also and the song also. That was one of the ways Amir Khan introduced himself in the class with students.
Yeah.
So there are many different ways how we can introduce our topic or ourselves in an interesting way. But that was quite bold step, which we people can't take it most of the time. And it's a very challenging, bold step.
And also risky.
Risky. Like the way
it can backfire.
Yes.
Especially with the healthcare professionals, if you are little, too kind of casual.
Yeah. This I just wanted to differentiate between the audience, like what type of audience you have.
Yeah, true.
If it is children, then this kind of this thing.
Yeah.
I'll give you one more example. This is one of the professor, a leading economist, was about to deliver a lecture to a huge group of college students back in 2010 in Harvard University. The lecturer asked for a cup of tea before starting the session and surprisingly asked for an empty cup of tea also. This is a real life story. It wasn't surprising that the students were not paying the due attention to the speaker. This brilliant man standing at the head of the auditorium dropped the empty cup and announced, "China has fallen." This smart play of 3 words was how he made sure that every attendee was hooked onto what next the speaker had to say. The topic he was about to cover was the economic collapse of the Chinese economy back at that time in 2020. So just with a small tricky movement by throwing the cup of, which was made up of bone china, he announced his topic, "China has fallen." This is one of the example of introducing the
Very interesting.
topic. We have various options available. We have discussed also in our classes and we have done many activities also. There is plenty of n number of topics we can decide or activities we can think of in this, like for starting the first time, how interesting, in an interesting way we can introduce the topic. There are numerous ways. Can anybody suggest few? Like if everyone says 2 topics, we can have around 20. I have listed many also, and everyone can suggest also 1 or 2 top activities which we can introduce in the topic in an interesting way.
So last time, like Renu had done puzzle, that was a good idea.
Yeah, puzzle was a good idea. Then anything like role play, you can start with some quote, you can start drawing a picture on the board and then you can introduce your topic. Yeah. Then you can start with some facts, statistical data, research findings, even by storytelling, and some audio, video. Like today, Bindu ma'am has started with a video, or you can start with some audio and then you can introduce your topic in an interesting way. But having a topic in an interesting way is very, very important thing to start in a session, which is most of the time mostly ignored. My personal suggestion is to find your Ramban in every session, or a sub-session, or any other quote. You can do that. The introduction of your topic session should always be apt for the audience, true to the topic. Apt means apt as per your topic session of the day, or as per the audience also. It should be interesting, always interesting, so that you can hook up on the audience or the clients, whosoever is there. then it should be innovative. Well, we all have been thinking out of the box ever since that box was built. So innovative ways can be introduced, and every time you can have an innovative way. Then
Thank you. Wonderful.
so I already introduced myself as I'm first timer with virtual this thing. So this was going to happen, I knew.
No, but we are happy with what you presented. It's
Okay. Okay. Thank you for encouragement.
that's
Very
it.
well,
Yes.
very well crafted, Poonam ji.
Okay.
बहुत innovative था आपका.
Poonam ma'am, it was to the point, and what we were looking forward to, and you have put everything like now. You have taken the jewels and put it in a box and presented to us.
Okay. Thank you. There might not be any questions, I am sure. Very simple it was.
So we understand, but the importance of, I think, introducing
Importance.
innovative is very important, because it's
Indu ma'am will highlight the.
well begun is half done. Well begun is half done. If you are able to get the attention of your audience right in the beginning, then it's easy to sustain. But in case even in the beginning, if you miss that opportunity of engaging them, then it becomes difficult to engage them later.
Later.
And the first impression actually forms within a couple of seconds. They have about the trainer or the program or the session. So we need to be really very, very innovative in finding a good ways of introducing, the topic in a very innovative way. Thank you. Wonderful.
Thank you. Thank you, everyone.
Thank you. So I think with this we come to the Dr. Samira. Anything you wish to say?
No, thank you. Wonderful. Thank you. Thank you so much.
Thank you. So because usually you wait for your turn, so I thought I must call you by name and ask you in case if you have something to share or ask or say something. So with this, we come to the end of today's session, but this is not the last session. So we have one more additional session on the next Tuesday. So please prepare an outline and write in that link so that everybody knows who is working on which topic, so that there's no repetition. And now we are not working in groups. Individually, you have to write your own, identify your own group and write the outline for that program. And do it as early as possible before the other person takes your topic. And then you say, oh, I wanted to write on this. So do it as early as possible and make your entry so that we know you are going to work on it. And let's meet on next Tuesday and conclude this program. Thank you so much. Good night, everyone. Bye-bye.
Ma'am.
Yes, please.
Ma'am, I missed the beginning.
Sorry?
I missed the beginning. So what is this all about in the next session?
Yeah. Actually, what we have decided, everybody is supposed to write an outline for for a program, for a 2 hours program. So that was supposed to be a group activity to be presented today. But since we decided to cover this topic of disclosure of medical error, so we have added additional topic for all of us. I mean, additional session for on next Tuesday, where each one of you will be presenting your group work, that activity that you're supposed to be doing on designing a 2 hours program. You have to write an outline, also tell what activities you intend to integrate or any questionnaire you have on your mind and how you're going to run the show. So more like a sample outline we want from each one of you. And also, Isha, I hope you remember.
Not the entire session.
Sorry?
Not the entire thing, just the outline.
No, just 5 minutes presentation. See, each one of you will get total 10 minutes, 5 minutes for the presentation and 5 minutes for everybody to ask questions or give their inputs to make the training more, useful and meaningful for everybody.
That slides has to be made, or you can just present your things how you want to go about it.
It's better if you have a couple of slides to showcase everybody, because you may have the idea in your mind, but people can only visualize it if they're able to see in audiovisual way. Dr. Samira, I think you wanted to say something.
Yes, I already sent my.
So you can
so-
improvise on that, work on that, and convert them into couple of slides, maybe 5 slides. That's all. Not more than 5 slides, if you can. So maybe you will give an outline, then you will write what activities, what questions you intend to ask, where you can elaborate on that. Okay. So you require not more than 5 slides to explain what outline you are suggesting, what activities you are integrating, and how you intend to run the show.
So I will put this information in PowerPoint.
Yeah.
Instead of in Excel sheet.
That will be better, no? Then you will be able to show to all others. Yeah.
Okay.
So let's meet next Tuesday. So Isha, I mean, I think you haven't done this activity also of showcasing your pedagogy, and you, I think you missed that opportunity. Isha, are you there with us?
Yes, ma'am. I was supposed to call you, but since yesterday I'm just not doing well.
Okay. Next week when we meet, we can start with your presentation first. You can do your task for 10 minutes, and then we will have everybody's presentation. Is that okay with you?
Yes, ma'am.
Okay. Because I want everybody to practice something and showcase something. No, only then it's called hands-on training. Otherwise, it's more like a webinar.
Sure, ma'am. Sure.
Okay. Chalo, let's meet next Tuesday, 8 o'clock.
Yeah. Thank you.
Isha, get well soon. Our prayers for you.
Thank you so much, ma'am. Thank you so much.
Take care. Bye-bye. Good night.
Thank you. Bye-bye.